To thank the organizers for having me here, and I start all my presentations with acknowledgements to my teachers at Sion Hospital and at LV Prasad Eye Institute and my teachers in counseling psychology. The session is on imaging in uveitis and my talk is on B scan and UBM. It's a very basic talk and we are talking about 7 case scenarios. I'll be quickly going through all of them and we'll have a take home message slide in the end. We are talking of the first case scenario, that is severe anterior segment inflammation. This is a 17-year-old adolescent with severe redness pain in the right eye, 5 days duration, and with a history of pain during urination for the past 1 day. You can see an organizing AC fibrinous exudate. The vision in the right eye was hand movement close to face, and there was a no view of the fundus. The message here is that don't think this is only an anterior uveitis. It's better to ask for a B scan. The B scan in this patient showed few mobile vitreous echoes with marked thickening of the choroid at the posterior pole. There was no retinal detachment. On a little more inquiry, the patient was complaining of early morning lower back stiffness, and he himself confirmed that he had a urethral ulcer in the past and even now. He was tested for HLA-B27 where he was positive. He was treated with oral steroids, intensive topical steroids, cycloplegic agents, and immunomodulation with oral methotrexate. This is a case which highlights a more extensive involvement because of HLA-B27 more than the anterior uveitis that we all talk of. This is the second case scenario, that of necrotizing anterior scleritis. Now this is that of a 58-year-old lady. She had recurrent redness pain in the left eye, 6 months duration, was treated in the past 3 years back with tuberculous meningitis, a controlled hypertensive on treatment, a patient of hypothyroidism, controlled with bilateral knee joint pain since the past 10 years. So we have bilateral knee joint pain, we have tuberculous meningitis, and we have the history of scleritis. This patient had a scleral necrosis. You can see the area of scleral necrosis here with the scleritis. This patient was investigated, turned out to be ANCA positive, strongly ANA positive and strongly positive for thyroid antibodies. The Mantoux test was done, but it was obviously positive. She had suffered from tuberculosis in the past. The ESR was raised. Here we did a UBM. This was a UBM just to document the scleritis. You can see the marked diffuse thickening of the sclera and the area of thinning and associated thickening of the ciliary body. This is the patient, the same patient on oral methotrexate. This is the picture at 4 months of treatment showing the resolution of the scleritis. This is the area of scleral thinning. Although the eye is inactive, you can see the scleral thinning now. The disease was monitored then using ESR and ANCA levels. This is the third case scenario, that of tuberculous inflammatory iris nodule. This is the eye of a 52-year-old lady who had recurrent redness left eye, 5 months duration. You can see large granulomatous KPs in the Arl's triangle, but these are two areas where the iris appears elevated. So we requested for the UBM, and the UBM showed this picture, inflammatory iris nodule, which was extending into the ciliary body. We obviously suspected tuberculosis, requested for an ESR, which was raised. Her HRCT was normal, but a Mantoux test was strongly positive. This is a 2009 case when one would request for an HRCT. In current times, we would request for a contrast chest CT. Patient underwent AKT total 9.5 months, after which she developed a complicated cataract. I would like to re-emphasize here that before doing the cataract surgery, it's best again to resort to USG-B scan and a UBM to look for cyclitic membranes. Patient underwent cataract surgery. The USG-B scan UBM was both normal, and this is a picture 2.5 months after cataract surgery. Vision of 6/9. This is the next patient to highlight a choroidal tuberculoma. This is a 26-year-old lady who had been on treatment of systemic pulmonary tuberculosis, came to us with a mild episcleral congestion of the left eye since the past few days. To highlight the importance of dilatation, on dilatation you see this, which is something like a scarred choroidal tubercle, but far there in the periphery you can see a huge choroidal granuloma. What we did was a UBM over the choroidal granuloma to look for any scleral involvement. There was no scleral involvement, but on B scan we saw the dome-shaped choroidal elevation. Always when you request for the B scan, it is always good to request for the A scan vector. You can see the A scan vector over here. The patient has since been on treatment of systemic tuberculosis and is on our follow-up. The next case is that of posterior scleritis. This is a 12-year-old boy who had drooping of the left eyelid 1 year back, presented to us now with redness in the left eye. You can see the left eye redness. On fundus examination, a mild disc hyperemia with a pocket of subretinal fluid between the disc and the fovea, which prompted us to think of posterior scleritis, and hence we asked for a B scan. You can see the B scan, a mild disc hyperemia. The B scan shows the typical T sign of posterior scleritis, and on the OCT you can also see the little retinal elevation that's there because of the pocket of fluid. This patient was further had a dermatology workup because he had these lesions which were present on the axilla and the chest, and ultimately we came to a diagnosis of this syndrome which is called PAPASH, which includes pyogenic arthritis, pyoderma gangrenosum, acne, and suppurative hidradenitis. This patient has been treated with oral azathioprine and is been on treatment since then and is doing well. The role of B scan in the diagnosis of VKH disease cannot be overemphasized. Many times in VKH, you're going to have a very hazy view of the fundus and then may want to resort to B scan. This case is not so. Here we've had a clear view of the fundus. A 41-year-old lady presented with sudden loss of vision, 4 days duration, no complaints suggesting of meningismus or tinnitus, a diabetic on treatment. This is the fundus picture on presentation, and the FFA showing the various stages. I've just put the late stage over here, the late phase showing the pulling of the dye. And here in the B scan is important because the B scan will typically show a peripapillary choroidal thickening and the elevated retina. These, you can see the pockets of retinal elevation are also obvious over here. The corresponding A scan vector. This patient was a case of ocular VKH treated with methylprednisolone, immunomodulated with cyclophosphamide pulses and oral azathioprine to achieve good vision. B scan findings in VKH disease have been highlighted. Patient will have choroidal thickening, retinal detachments and choroidal detachments. Almost 90 to 95% of the patients will have a choroidal thickening in VKH disease. Coming to the last case scenario, this is a pediatric pan-uveitis. Again, a highlight of the fact that HLA-B27 can cause a much more severe disease than one would think of. 13-year-old boy, known case of spondyloarthropathy, HLA-B27 affected in the left eye, treated with all possible agents before coming to us on prednisolone, sulfasalazine, methotrexate and infliximab. A very severe non-granulomatous anterior pan-uveitis, and we requested use of subcutaneous adalimumab. The patient still had multiple relapses, and you see this eye has now become hypotonous. We went back to the history to check whether the patient was compliant, and we found that the family had not been adhering to the treatment regimens. The entire family was counseled, and after sticking to the treatment regimen with the use of adalimumab injections, there were no further relapses. This is probably the most important message, the next message, as that is the eye had been quiet for about 3 months. The patient had a complicated cataract, and here it is always important that all of us anterior segment surgeons request for a B scan and a UBM. That's because we will come to know when to hand it over to the posterior segment surgeons. In this patient, the axial length by B scan was almost 18 millimeter. The radiologist felt that it was a pre-thusical eye. You can see the severely disorganized anterior segment on the UBM with cyclitic membranes. So when you have cyclitic membranes on UBM, a picture like this, always best that you involve the posterior segment surgeon first up. So we counseled the patient for a lensectomy vitrectomy with a silicone oil injection, And this is the outcome, a very early outcome. This is almost 5 days post-op. The patient has been since then on follow-up and has had affection of the other eye as well. So, coming to the last, the take-home message: in severe anterior segment inflammation, always best to do a B scan to look for posterior segment involvement. Necrotizing anterior scleritis, one may use a UBM to document the scleral thinning, although it may be very obvious on clinical examination. Whenever you are seeing elevated iris nodules in a case of tuberculosis, it may be a good idea to do a UBM to look for the nodules on the iris. In choroidal tuberculomas, you can document them with B-scan. In fact, B-scan has got multiple features with which you can differentiate between various choroidal masses. Posterior scleritis, many times we have absolutely quiet eyes and patient complaining of severe retroorbital pain. It's a good thing to do a B-scan, which is very non-invasive, and if you end up seeing the T sign, then you know you're dealing with posterior scleritis. VKH disease, looking for peripapillary choroidal thickening on a B scan can be important, especially if the view of the fundus is not very clear. And in cases of cataract with severe hypotony, always a B scan and a UBM to know when to hand it over to the VR surgeon. Thank you.